Okay, so thank you very much for coming today. So my name's Alvin. I'm the medical legal lead at Mind the Bleep, and today we have Dr. Divesh Prithviraj, who will be giving a lecture on advanced care planning. So this is the seventh of our medical legal series. Yeah, it very much dawned on me that we're getting towards the latter ends of this. So yeah, and thank you very much for all tuning in. It's been great that we've been able to share this with you. So, as always, as I'm sure you've heard on previous webinars, so some ground rules. If you have any questions, so this functions like a YouTube Live. So please comment on the YouTube Live comments, and then I can have a check on my phone. And when it's appropriate, I'll let Divesh know. Otherwise, we'll be putting a QR code at the end or towards the end that will show up on the screen. You'll be able to scan that and provide, so in order to get the certificate, you'll need to complete that. And you'll be able to provide what went well as what we can improve on. And that very much helps with the broadcasting of future webinars. Okay, well, in that case, Divesh, if you would like to take the scene.
Sure. Thank you very much, as always, Alvin, for the introduction. So I'm Divesh, I'm an internal medicine trainee, and today I'll be delivering a presentation on advanced care planning. So before I begin, can I just double check that the screen is visible, showing the title slide?
Try sharing the screen. There's a little button on the bottom left. Press that one, and then I can let you.
Yeah, I think. Can you see the presentation? Sorry.
No, not yet.
Okay, I'll stop screen sharing then, and then just. Entire screen.
There we go. Yeah.
Yeah. Can you see this now?
Yeah, so I can see that now. If everyone else can see it as well, please comment on the YouTube, and we can get going.
Cool.
Okay.
All right. Should I
okay, looks good from my perspective, so I think we can go ahead, Divesh.
Sure. So today's session will be on advanced care planning, and our aims in this session is to outline some of the principles underpinning advanced care planning, when and how to initiate these discussions, and subsequently covering advanced decision to refuse treatment and lasting power of attorneys as well. We'll briefly touch on do not attempt cardiopulmonary resuscitation orders, and then have a think about how to basically communicate all of these different topics in a sensitive manner when it comes to discussions with relatives and families. So we'll start off with the first question. We'll give it about 30 to 40 seconds for this question and the subsequent ones as well. And then we'll just go through the answers. So the first question, so which of the following best describes an advanced care plan? Great. So the correct answer is option B. So an advanced care plan is essentially a patient's preferences for future care and support. So it's a record of all of that, and it outlines certain things with regard to preferences regarding medical treatments, resuscitation orders, and then plans for end-of-life care as well. So when thinking about discussions around advanced care planning, the reason why we want to do it a bit earlier on is because in a time pressure, when patients deteriorate, the time pressure can be quite anxiety inducing and fear building for patients and relatives as well. So having these discussions early helps to minimize the effect of those factors. And alongside that, when considering when a patient deteriorates as well, there's also the possibility that a patient will be too unwell to communicate any decisions regarding their care, in which case they may have lost their capacity. And so having discussions early helps ensure that when patients have capacity, or still, retaining their capacity, that they can outline exactly what they want and don't want. It also provides patients with an ownership over their own care. And when having these discussions, it's always important to emphasize that discussions are a dynamic process. So although certain points are being outlined in one discussion, it doesn't preclude further treatment discussions later on from being taking place. So again, the whole reason behind doing the advanced care planning and what to discuss is about what patients want and don't want, who else they would like to be involved with regard to decision making. So a lot of people will mention about their next of kin or close friends, for example, and their ideal sort of place of care. And one thing that's important to remember is that from the clinician point of view, that clinicians are not necessarily legally bound to administer any treatment that's deemed to not be beneficial. So that's something to consider as well. Now, discussions about advanced care planning can be, as I mentioned before, quite anxiety inducing and can cause a lot of stress and fear with patients. So there are situations where people will simply refuse to proceed with a discussion about end of life care or about further treatment options when their health deteriorates. And although ACP decisions are voluntary and patients can decline to know further information, it's always important to understand why. And once you understand why, then it helps facilitate bridging a solution to help to developing either a compromise or a way of having these discussions. In some situations, however, that may not be enough. And so it's very important to then respect a patient's decision, but then provide basic information so that valid consent can be given for proposed management options in the future. And of course, if there is still further declining, then it's always important to seek information from a third party organization, for example, a medical defense body, and then always keep yourself safe by performing adequate record keeping as well. So, when it comes to withholding information, generally, information should not be withheld unless there is concern that it may cause serious physical or psychological harm to a patient. And this has been demonstrated before with the Montgomery and Lanarkshire case and is also reinforced by the Mental Capacity Act as well. Again, always important to contact a medical defense body if there's a decision to withhold information and to also document very clearly the justifications of doing so, so as to protect yourself. And always consider reviewing the possibility of whether information can be delivered in the future so that it ensures that you are maintaining good continuity of care and reviewing a patient's preferences and wishes every so often. Now, shifting the topic more towards advanced decisions of refusal of treatment. So, the next question is regarding which of the following is a key legal requirement for a valid ADLT. Okay, so the correct answer is option C. So ADRTs must be signed and must be witnessed if decisions regarding life-sustaining treatment are refused. So they have to be ADRTs have to be made by someone who's over the age of 18. They don't automatically override an LPA, and as we'll come on to later on, there are certain requirements that have to be made for one or the other to be more valid than the other, and vice versa. So ADRT, or Advanced Decision to Refuse Treatment, are legal instructions outlining which treatments a patient would not want to have in the future. There are different nomenclature around it. So some people refer to it as a living will. Some people call it just abbreviated, to advanced decision. And in Scotland, they refer to it as an advanced directive as well. And it helps to ensure that patients have greater control over their long-term care, that whatever treatment options that they're given in the future, it does not prolong any unnecessary suffering. And it also helps caretakers and relatives to be relieved of decision-making burdens that may arise if they're, for example, the lasting power of attorney. So patients may refuse life-sustaining treatment on various grounds. In these sort of situations, patients should ideally speak to their primary and secondary care doctor to obtain all relevant information related to the effects of refusing or stopping treatment so that they can have all the information possible. And ADRTs must specify the following when they're documented. So firstly, which treatment should not be carried out, and exactly what situations some of those treatments should not be carried out. So just for a bit more clarity, which we'll touch on a bit later. So as mentioned before, patients must be 18 years or older to create an advanced directive. Everything must be documented very clearly and must be signed by the patient with a witness present as well. Again, they can be reviewed and amended at any point, and they're legally binding in England, Wales, and Northern Ireland, but not in Scotland. So, as mentioned before, the example here is the following. So, in terms of refusing to follow certain treatments in certain circumstances, so the example that I've given is refusing antibiotics for a chest infection in the situation that a patient has a terminal malignancy and becomes confused or unconscious secondary to that chest infection. Now, moving on to lasting power of attorneys. So, which of the following is true about a lasting power of attorney?
Sorry, Divesh, if we could give it like 20 seconds longer. There is someone commenting in the chat. It's just coming through a little slow on my phone. So we'll give
sure.
it like 20 more seconds.
That's fine. So I think 30 seconds have gone, so I'll just give it another 20 seconds. Yeah.
Lovely. And we've also got a question from Pavel. Does the witness have to be a legal professional? So if we just go back.
Yeah, sure. Yes, the witness. So the witness doesn't necessarily have to be a legal professional. The witness can be someone who is either, as far as I'm aware, known to the patient, or it may be a third party as well. But the underlying thing must be that the witness is not deemed to be in any way influencing the patient to be signing an ADRT for their own beneficial gain. Does that make sense?
We'll see if Pavel comments again. Yes. So moving on to the question, Pavel's commented question answered B as well.
Okay, fine. Great. Yeah. Should I give it a few more seconds for the question, or would you like me to move on and just discuss answer?
Yeah, I think we can move on.
Okay, sure. Yeah. So yeah, the correct answer is answer B. So lasting power of attorneys must be registered and signed to be valid. So lasting power of attorneys effectively are people who the individual has nominated to make decisions on their behalf when they lose capacity. There are two types of LPAs. So there's the health and welfare aspect, and then also the property and financial affairs. Um, Health and welfare, as the name suggests, apply to decisions regarding a patient's treatment, current management options, and what they want and don't want. And then property and financial affairs are, again, as the name suggests, with regard to their housing, mortgage, and other aspects about their finances as well. And the key difference is, aside from what exactly the LPA, each LPA governs, is with regard to when LPAs can make decisions. So for health and welfare, LPAs can make decisions only once a patient has lost capacity. But for property and financial affairs, lasting power of attorney, they can make decisions at any point. And of course, because of how much power is associated with uh, a lasting power of attorney, as someone who can make decisions on behalf of the patient, everything must be done in accordance with the principle of best interest. Um, as mentioned before, with advanced directives and about witnesses needing to not have certain agendas with regard to their own personal gain, it's the same case here. So if LPAs are deemed to be acting with regard to their to motivate and fuel their own personal interests, then they can be removed as an LPA, and it's actually considered a possible criminal offence as well. So they may be prosecuted for that action as well. So similar to ADRTs, LPAs must be 18 years or over. One LPA can be assigned for both the property and finance as well as the health and welfare. And alternatively, you can have more than one person assigned for each LPA role. Sorry. And in terms of then deconstructing that, patients, if they are indeed wanting to have more than one person assigned for each role, they need to specify exactly which decisions can be made jointly or individually so as to avoid any confusion in the future. And as mentioned before, with the form needing to be documented and signed very clearly, so the patient and a witness, as well as a certificate provider, must provide their signature alongside, the patient and their nominated LPA. So LPAs are only valid in England and Wales. The process is slightly different in Scotland and Northern Ireland. Partners or spouses are not automatically LPAs, and patients must specifically choose them as well. If the patient has not assigned a lasting power of attorney, then there's always the option of referring to the court of protection if someone would like to be assigned this role. Now,
Sorry, Divesh, I just wanted to interrupt you there. So we've got another question. How can the ADRT be legally binding without the document being legally signed? So I think there's a few slides back with regards to ADRTs.
oh yeah, the ADRT must be signed. Yeah.
Yeah, so specifically, if it's the ADRT must be signed if it's to refuse treatment, because otherwise it wouldn't be valid.
Yeah.
However, if it's sort of preferences, fine. It can be just witnessed, but something as important as refusing treatment must be signed for it to be valid.
Yes.
Yeah. Have it. Hopefully that answers. Well, hopefully that answers the question.
Hmm.
Sorry, if I interrupted your flow.
No, it's fine. But does that make sense? Is there any further clarifications needed for that question?
I'll keep an eye out.
Yeah. So, so in terms of ADRTs and LPAs, obviously, they both have their very specific roles and what exactly they govern and don't govern. So, if somebody were to have both an advanced decision to refuse treatment and lasting power of attorney, sometimes the wishes outlined in the ADRT may conflict with the wishes that have been addressed to the LPA. Either document can take precedence over the other, and from some of the sources that I've read, some have outlined that whichever one was made most recently would be deemed most applicable to the wishes that the patient would like. But ultimately, I think the main thing to stress is that both of these documents are important. And so, wherever possible, it's important that the information and the preferences and wishes of the patient outlined in both documents are aligned as closely as possible, as yeah, so as to avoid further conflict. So, yeah, I'll increase the time limit to about 50 seconds for this question. So, if no ADRT or LPA exists, then who has ultimate final responsibility for decision making of the patient? Okay, so that's 50 seconds up. So,
I've got one response. Ooh. E.
E, yes. So that's the correct answer. So if there's no ADRT or LPA, then ultimately the lead medical professional has the final responsibility with regard to decision making. So that doesn't necessarily have to be the patient's GP. It could also be someone from the secondary or tertiary unit looking after the patient. So in the event that there's no advanced ADRT or there's no LPA that's been assigned, then decision falls to the lead medical professional. And once again, decisions are always made in the patient's best interest as well. So it's always important to consider the situation, these sort of circumstances, because they do happen quite a lot. So it's always important as early as possible to establish what a patient would like, has wished for in the past, and then what they currently wish for as well. Whether they do have an advanced statement at the moment or have an LPA that they've considered but have not formally organized yet. And it's also important to consider the views of relatives, carers, and friends, essentially people who know the patient and can give a good account of exactly what the patient would want in a situation where they've deteriorated significantly. Best interest meetings are also very common, and they can be held to discuss a patient's care and obtain the views of the aforementioned people as well, to get a better idea of what treatments are considered suitable or inappropriate for a patient. And sometimes relatives may have disagreements or concerns with regard to a patient's care and about the decision making made by the medical team. And it's fully within their list of options to ask for a second opinion referral to be made or to seek input from the Court of Protection as well. Sorry, before I move on to DNA CPR, can I just check, are there any questions at the moment?
Yes, so we've got a question. Who constitutes a certificate provider for LPAs?
So I believe that I don't know of the exact organization, but I think there would be a official certificate organization provider who governs that. I'm not too familiar with that specific area, so I don't know if there's one specific organization that does that or multiple. But what I would imagine is that the hospital would, hospital or the GP practice would have contacts with regard to the first point of call to establishing establishing a certificate for an LPA or ADLT. Do you know anything more about that, Alvin?
Yeah, I think specifically for, well, it can be initiated with any healthcare professional, firstly. I think specifically a certificate provider has to be someone, so it can be healthcare staff, so often GP, any clinician that's taking care of the patient, as well as I think the other broad category is someone who's known the patient for over 2 years. Importantly, can't be a family member. And but in terms of initiating the process, yeah, it can be, with the healthcare professional. I also don't know exactly what website I would use, but yeah, I'm afraid I just know what a certificate provider is.
Yeah. Are there any other questions?
So far, no. So we'll if there are any other questions, we'll keep them to the end so that we can push through the last bit.
Sure.
Does that sound good?
Yeah.
Lovely.
Cool. And now, shifting away from that, we're going to just briefly touch on do not attempt cardiopulmonary resuscitation orders. So, as we all know, CPR is something that is a procedure which attempts to restart a person's heart if it were to stop beating. Sorry, yeah, if it were to stop beating. I believe that is an error in terms of vocabulary, but CPR, so the main thing to consider with CPR is that it is quite an invasive process. It involves chest compressions, lines being put into the body, into bones if necessary, and then also electric shocks as well. So it's quite a taxing process, and it can be successful in some situations for some people, but not others. And in situations where it's unlikely to be successful, there's a do not attempt CPR decision that's made. And that's to ensure that the patient's dignity is preserved and to minimize how much suffering that they may endure as a result of resuscitation. So, DNA CPR decisions are made by the medical team in charge of the patient's care. And there is a lot of contention and a lot of debate about exactly what the role of relatives are in this, in decision making. So relatives do not make the decision. They're not necessarily involved in the decision. However, because the process itself and the ramifications of not performing a treatment to restart the heart are quite significant. It's always good practice to have such discussions with relatives and with patients as well. And it's, as mentioned before, it's always best to do these things earlier on rather than in an emergency, as there's a lot of emotions, there's a lot of stress that's often going around. And in terms of actually carrying out these discussions, obviously, it's very difficult to have these discussions when a patient is very well, because people, when they're very well, may not necessarily think about what could happen if their health were to deteriorate very rapidly. And they may find it very difficult to comprehend that because they've probably never thought about it. So it is a difficult discussion, and typically it's one that's often led by a senior member of the team or someone who has had experience with these discussions on several occasions. And although they are very specific with regard to CPR itself, they don't have any bearing onto other aspects of patient care. So, a patient having a DNA CPR order, for example, does not preclude them from necessarily having very strong antibiotics or associated treatments for other conditions. And why that's important is because whenever facilitating these discussions takes place, a lot of people have the misconception that not performing CPR means that all treatment stops. And it's very prudent to outlining that that's not the case, because a lot of people, when they think that treatment stops, obviously they will be very adamant that such an order is not instilled. So it's a very sensitive topic, but it's one that if you break down and deconstruct in small pieces, it helps bridge the gap towards having a mutual understanding about things. Yeah, and that was a very brief sort of run through to do not DNAR orders. I've now just put my references on here so that if you have the chance, you can delve a bit more deeply into some of these topics. So as you'll see, a lot of my content was based off of information from the GMC, Dementia UK, Macmillan UK, and gov.uk as well with regard to mental capacity. So these are all very good resources, and I strongly encourage you to have a good read as well, just in the future. And that.
Well, thank you very much, Divesh, for once again another crucial topic. I'm going to quickly put up the QR code just in case. So up here, you may be
You
able
want
to
me to exit? Sorry.
Yeah, if you stop sharing the screen, then we'll be able to show the QR code. So I'm going to go through this. So top left, your top left, there's a QR code. If you'd like to scan that for feedback, as well as the certificate for you guys. So thank you once again. Thank you very much for the talk. I think advanced care planning, not that it's necessarily overlooked. I think it's a consequence of services being stretched, and I think especially in sort of geriatric wards, well, I guess other patient profiles as well, it's very important to stem the flow from primary care. I'm sure all of us as clinicians have experienced many a time where we've seen the patient who's in hospital that doesn't need to be in hospital, comes in with almost no documentation about what their preferences are, nor well, sometimes not even with a DNA CPR or a TEP-in. And I think knowing sort of how to initiate these processes is very important, both in primary care and in secondary and tertiary care as well. So thank you very much, Divesh. It's been
sorry. Just before we continue, I think I'm just reading the chat. I think Pavel just had
Oh, yes, yes.
about cases where a medical professional would decide not to resuscitate. Are
Ah,
you happy for
perfect.
me to answer that first?
Yeah, of course, please do. Please
Yeah.
do.
So it's a good question actually, and I think it's one that um, doesn't necessarily get touched on enough in top topics and talks with regard to um, DNA CPR um, discussion. So um, certain factors are um, the frailty status of the patient. So there are different ways of assessing frailty, but generally, when we think about frailty, we consider exactly how good the patient is functionally. So, um, in terms of the social history element, um, how they mobilize. For instance, are they independently mobile, or are they needing a Zimmer frame, or are they housebound? Um, and then in terms of actually managing their activities of daily living, are they fully independent, or are they fully reliant on staff members to come into their accommodation and help them with their cooking, cleaning, changing, um, and what their exercise tolerance is. So how far if they are mobilizing, how far they can mobilize before they have to stop. So um, say, for example, someone who's housebound, who is considered very frail, is not able to manage their activities of daily living, so has quite a poor functional status. The um, clinicians would be more inclined towards considering a do not attempt resuscitation in that situation. And a big part of that is because CPR, although it can restart the heart, there is a very high probability that it won't restart the heart. But worse than that, it may restart the heart, but then leave patients with an even poorer functional baseline than what they were prior to that. So if we consider the example of someone who's housebound, who's reliant on other people, then um, a baseline that's even worse than that is something that can be quite intolerable for a lot of people. So in the context of best interest, that would be deemed inappropriate. So the social history aspect is very important. And then in some situations, depending on which clinicians you speak to, some people may look at comorbidities as well. So, someone who has quite a lot of different conditions in different organs of in and around the body, that would influence them towards enforcing a DNA CPR order as well. Um, and generally speaking, as well, what has brought them into hospital. For example, if they've been brought in and they're suffering from something that's like a very severe chest infection where the chances of recovery are very low, then those aspects may also make clinicians consider not resuscitating as well. Ultimately, there's lots of things that you have to look at, but those are the big ones. And if you're ever in doubt about who to resuscitate, it's always good to have a discussion with the lead clinician, for example, either or the consultant, basically. Is there anything that you wanted to add on top of that, Alvin?
Um, no, I think that's pretty good. So yeah,
Um,
that was common advisable in heart failure stage 4,
yeah.
for example. Yeah.
So yeah, I think that's so it's difficult to answer that
Mm.
question because yeah, although I've only spent 2 slides on it, resuscitation discussions are quite complex. So it's a multifactorial thing. So there's different things you have to look at. Because someone who has heart failure stage 4, yes, they've got quite bad heart failure, but actually functionally they might still be okay. Whereas someone who has heart failure stage 4 may be on the other end of the spectrum and maybe mobilizing very poorly, maybe very reliant on other people. So it's very difficult to answer if it's advisable or not. You have to take each patient individually and then look at different aspects of them as well.
Yeah, I'd completely agree as well. You have to look at the patient holistically, often comorbidities, functional status, social history, as well as current situation as well, biochemical markers such as observations at the time. It's so dependent. And then once again, you have to consider the patient's decisions as well. What sort of management would they want to receive, and have they made any advanced decisions, whether it be advanced decisions. There are actually, I remember one of my care of the elderly consultants telling me, there are calculators you can use online that actually predict it predicts survival. Some predict survival, others predict survival with the same quality of life. And when you actually start to plug the figures in, it is pretty astounding how low the success rate is, and gets even lower if it's an out of hospital cardiac arrest as well. So a lot of things to consider. Also, coming back to the point about LPAs and certificate providers. So I quickly did a search. It's still part of the LPA process. So be initiated by the Government Department of Public Guardians. So as part of applying for an LPA, certificate providers and witnesses would come about through that process. So hopefully that clarifies some things for you guys. Otherwise, if wait another minute. But yeah, no, thank you very much, Divesh. Looking forward to the next one. Yeah, as I was saying earlier, often overlooked point, and I think it's important that everyone has an idea of putting preventative plan. This is essentially a preventative plan in. So stop people coming in from hospital, stop that cardiac arrest in that clinically, well, CFS 8 multi-comorbid patient that ends up in resusc, has been intubated, well, has had multiple rounds of CPR as well as adrenaline, and the decision is made as soon as they come into resusc to stop. It's to prevent that. Let people have what they want and pass away in circumstances that they would prefer, I think. Hope you agree. Anyway, well, thank you very much for coming to this session. So I believe it's in 2 weeks' time, on the 17th, we have our next session with the DT. So she'll be doing a lecture, giving a webinar on research ethics. So very much excited for that one. A slightly different approach compared to the previous lectures that we've been giving. They've been mostly working on clinical work. So very excited for that. Hope to see some of you guys there. Anyway, take care, and thank you very much for coming. And thank you very much, Divesh, for giving this webinar.